This is a review for the respiratory chapters. There's 3 of these reviews. Look for the PowerPoints to come. All right, so this is just general respiratory. The client is diagnosed with asthma. Newly diagnosed with asthma, ask what triggers to avoid. Select all that apply. Options are beer, molds, perfumes, animal dander, warm, moist air. So, newly diagnosed with asthma should avoid beer, molds, perfumes, and animal dander. Moist, warm air is what you want. A patient with a chest trauma has been intubated with an endotracheal tube, or ET tube. The nurse checks the patient after the ventilator alarms high pressure and notes absent lung sounds in the right lung. The nurse immediately checks for other signs and symptoms of which a right pneumothorax, pulmonary embolism, a displaced ET tube, or acute respiratory distress syndrome. So the patient was in a trauma and there's high pressure in the right lung. So it's probably not a pulmonary embolism, and it's not acute respiratory distress syndrome. That's the right pneumothorax that you're looking for. There's high pressure because there's too much air going into the right lung. So this is an endotracheal tube here. So it goes into the airway, and you see the airway and the GI tract share, and then they split off. So an endotracheal tube it's going into the trachea, and this cuff is blown up to keep it in place. Then the esophagus over here. The nurse is evaluating a patient's need for tracheal suctioning. The nurse determines that suction is needed if which of the following is noted: an oxygen saturation of 95, congested breath sounds in lung fields, a respiratory rate of 18, 2 hours since last suctioning. So we can eliminate at least 2 because they're within normal limits. So the oxygen saturation of 95 and the respiratory rate of 18 are normal. That's good. 2 hours since last suctioning, that doesn't necessarily mean anything. But congested breath sounds in the lung fields, absolutely. Also, if you have diminished or you can't hear lung sounds, suction. Don't sit there and try to, spend too much time seeing if you can hear lung sounds. If you don't hear lung sounds, suction. The nurse is discussing acute respiratory distress syndrome with the provider, who states that due to fluid in the alveoli, surfactant production is decreased. The nurse interprets that the decreased surfactant is a complication of what? Atelectasis and viral infection, bronchoconstriction and stridor, collapse of the alveoli and decreased compliance, decreased ciliary action, and retained secretions. So the answer is collapse of the alveoli. See a normal on the left and collapsed alveoli on the right. Which are risk factors for developing pneumonia? Select all that apply. Gastric feeding, stroke, prolonged immobility, regular physical activity, consumption of soft foods, immunosuppressive medications. So gastric feeding, they can't aspirate. Stroke, they can aspirate. Prolonged immobility, they can have atelectasis. This is why you want to turn, cough, deep breathe. And if a patient is unable to move themselves, you need to do passive range of motion and move them. Immunosuppressive medications will make a patient an immunocompromised patient, which just means that their immune system is decreased. This is very common for patients with cancer. Cancer medications suppress the immune system. Regular physical activity is good, and consumption of soft foods. If it was consumption of liquids, that could be a risk factor. Which of the following is not an expected outcome in a patient with pneumonia on antibiotics for 2 days? Improved breathing, a fever of 102, respiratory rate of 18, and eunypnia, which means normal breathing. So it's fever, a fever of 102. That fever should have started to decrease, but between 48 and 72 hours, antibiotics for respiratory infections should pretty much be resolving the issue. So respiratory rate of 18 and normal breathing are the same thing. So if you ever see answers that are basically the same thing or the same thing, it can't be both, so you can eliminate those. The nurse is caring for a patient following a left pneumoectomy. So that means that they had the left lung removed. What position should be avoided in the care of this patient? Semi-Fowlers, elevate head of bed to 45 degrees, supine with the head elevated, left lateral with the head elevated. So think about left lateral. Patient had the left side of their lung removed. Left lateral means what? So left lateral means that you're lying on that side. If it was right lateral, the patient would be lying on their right side. So this should be avoided. You don't want the patient to be leaning on their operative site. C doesn't tell you. It doesn't tell you how much the head is elevated. Don't assume it's not an adequate amount. The head of the could be elevated at 45 degrees. And semi-Fowlers, those first three answers are kind of all the same, and they're appropriate. The nurse is caring for a patient with laryngeal cancer, is assisting the patient with filling out a dietary menu. The nurse should encourage the patient to select foods with what type of diet? Low calorie, low protein, high calorie, low protein, low calorie, high protein, or high calorie, high protein. I hope this one is an obvious one. High calorie, high protein, they're coming from a serious illness. They need calories and protein, extra calories and protein. The nurse educator is describing the risk factors of laryngeal cancer to a group of nursing students. Which statements, if made by the student, indicate a need for further teaching about these risk factors, meaning that the student is incorrect? So options are exposure to mold, cigarette smoking, exposure to radiation, frequent respiratory infections, combined use of tobacco and alcohol. So select all that apply. So mold and frequent respiratory infections are not risk factors for laryngeal cancer. Cigarette smoking, radiation, and tobacco and alcohol combined use are risk factors for laryngeal cancer. The best position for a patient after thyroid surgery is prone, Fowlers, side lying, reverse Trendelenburg. So think about where the thyroid is and where the incision would be. And also think about if there was any swelling in that area, what could that affect? So it's Fowler's. Patients that have thyroid surgery usually will have a drain for a few days. They need to have their head elevated. And if you have swelling there, that's going to affect the airway. If this area is swollen, that's not good for the airway. And just a little side note, when patients first come out of thyroid surgery, they'll have a big dressing, real bulky dressing. So you need to check for bleeding behind their neck, behind their back. Don't just assume that it would all be in the front. It can roll behind the patient and be pooling. The nurse notes a patient is having irregular respirations with periods of apnea. Apnea means that there's a pause in the breathing. The nurse documents this as which type of respiration? Ataxic, apneic, Cheyne-Stokes, neurogenic hyperventilation. So the answer is Cheyne-Stokes. So there's rapid, 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 no breathing. Rapid, 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 no breathing. That's not good. Another select all that apply. The nurse recognizes that which are risk factors for the development of respiratory disorders. Surgery, allergies, chest injury, crowded living conditions, and the use of incentive spirometry. So this says respiratory disorders. It doesn't say chronic, acute, upper, lower. So anything that's a respiratory disorder, which one of these could affect? So surgery, obviously, atelectasis, fluids building up, you can get pneumonia. Surgery, you could, if you aspirate, especially if it was an emergency surgery or the patient was not NPO, and they aspirate and get aspiration pneumonia. Allergies can affect the upper respiratory, and crowded living conditions, you're more prone to get infections. So a chest injury isn't going to cause a disorder. It's an injury, but it's not going to lead to asthma or COPD. And the use of incentive spirometry is going to be beneficial. So I just want to review the difference between incentive spirometry and peak flow, because a lot of people get these confused or they think that they're the same thing. So incentive spirometry, you're inhaling. So this is used after surgery, especially when a patient is not able to ambulate because they can't turn, cough, deep breathe well. So they're going to inhale and move the little ball or disc or whatever device they have up. And they're going to have a goal, and they're going to have a number of frequency that the nurse might assign or might be ordered for the patient. But incentive spirometry helps prevent atelectasis with deep breathing, good lung expansion. So incentive spirometry, you inhale. Now peak flow, which a lot of people call peak flow, but it's actually peak expiratory peak flow. So that tells you what it does. You're exhaling. And this is mostly for people with asthma. So you can see there's a red, yellow, and a green zone. So depending on where they fall, they know how they're doing. And when a patient has an asthma action plan, whether they're in the red zone, the yellow zone, or green zone, determines what their treatment should be for that. And red zone is almost always like 911. That's they're not doing well. So that's the difference between a peak flow and an incentive spirometry. And if you forget that peak flow is expiratory, remember incentive spirometer is in and the other one is out. And there are other respiratory tests, but these two get confused a lot. Oh, the nurse is reviewing medication orders for a preoperative patient who is to be NPO after midnight. The nurse should clarify whether which medication should be given to the patient preoperatively. So one of these medications, you think that you should be giving preoperatively, and you want to make sure which one to give. So options are iron supplements, atenolol, which is a beta blocker for blood pressure, cyclobenzaprine, which is Flexeril, that's a muscle relaxer, or estrogen cream. So there's two that I'm going to eliminate right now. Iron supplements and estrogen cream, you can go a day without those. It's not going to make a big difference. Cyclobenzaprine, Flexeril. Well, you can live without that. You may be a little uncomfortable, but you're about to have surgery. Maybe you don't want something that's going to depress your respiratory system before you have, anesthesia. So that's not life or death. But the blood pressure medication, especially when you're about to have surgery, that is important. Beta blockers are almost always given the day of surgery. Some other blood pressure medications may not be given, but usually beta blockers, it's actually a measure that they track for surgical patients. They should be getting their beta blockers. So if somebody's having surgery and their blood pressure is really high, they're going to treat it in the OR. They don't want their pressure to be so high that they're bleeding from every crack and nook in their body. So you want good blood pressure control during surgery. So beta blockers, if the patient is going to get any medications day of surgery, it may be a beta blocker or their diabetes medication, or it might be a different dose, but they will get the beta blocker and they will get the diabetes medication. The nurse is reviewing ABG results. The results are a pH of 7.28, CO2 of 2, or excuse me, CO2 of 50, and bicarb of 24. So is this respiratory acidosis, alkalosis, metabolic acidosis, or alkalosis? So I want you to stop the video for just a second and try to figure this out on your own. Okay, so first of all, the pH is 7.28, so you know it's acidosis. The CO2 is high. So you have one that's low and one that's high. Opposite, right? So it's respiratory acidosis, respiratory opposite, metabolic equal. So pH 2 is low and the CO2 is elevated. So that's respiratory acidosis. The nurse is caring for a patient with laryngeal cancer. Which intervention is the highest priority for this patient? Place the patient in Fowler's position, administer pain medications, provide respiratory treatments, monitor for respiratory distress. Okay, so you know ABC. These are kind of all A questions, but one is a safety question. So ABC, but safety always comes first. So when they're saying respiratory treatments, that could be anything from oxygen to a nebulizer treatment, or maybe they have COPD and they have to get those medications. I mean, it's kind of a general option here, respiratory treatments. Monitor for respiratory distress. Yeah, so right now I'm going to put that one at my highest priority. Pain medications. Pain medications are definitely not the high priority. Now, a patient has cancer. It's probably going to have pain, but it's not the most important thing here. Place patient in Fowler's position. That's going to prevent problems from happening. And that's your first choice. So monitoring for respiratory distress, I would say that falls under the A and ABC, but keeping them from having respiratory problems in the first place, placing them in Fowler's position, is the priority. What are some signs of lung cancer? The nurse will teach a group at a community health center. Select all that apply. Signs of lung cancer: a cough, wheezing, chest pain, hoarseness, or abdominal pain. All of them but abdominal pain. somebody who has a hoarse voice and it doesn't go away, and especially if it's kind of new and not, like they didn't talk like that before, and they're having other symptoms, that's definitely a red flag. Coughing, wheezing, chest pain, all of those are. And for chest pain, we're talking about respiratory, but when somebody has chest pain, you always have to rule out a cardiac cause. So don't assume, oh, they have respiratory problems, they're having chest pain, it's related to their respiratory issue. It could be related to a heart attack instead. So rule those out. The nurse is selecting supplies for a patient with epistaxis or nosebleed. Which would the nurse get from the supply room? Warm compresses and cold compresses, hot packs and aspirin, cold packs and gloves, cold packs and aspirin. So, what do we know about aspirin? It makes you bleed, right? So they have a nosebleed. So I'm going to eliminate B and D. They're not giving aspirin. Cold packs or hot packs, one of those might be a good option, but if part of the answers are wrong, the whole answer is wrong. So cold packs and gloves or warm compresses and cold packs. Well, it's got to be one or the other, and they have a nosebleed. I'm thinking I want my gloves. So that's the answer. Cold packs. And you're gonna treat that with cold packs, not heat. And you want the gloves. So remember, if any part of the question is wrong, the rest of it is wrong. So C, cold packs is right, and gloves. But D, cold packs is right, but aspirin is not. What position do you place a patient with a nosebleed in? Leaning backwards or leaning forward? A lot of people don't realize this, even nurses. So please, I want you to learn this. They're going to lean forward. So they're going to have ice packs, and they're going to hold their nose, and they're going to lean forward for 5 to 10 minutes. Forward. Leaning forward prevents choking on blood. You don't want them leaning backwards and having all that blood go down their throat. If the bleeding doesn't stop in 5 to 10 minutes, more advanced medical care is needed. An anterior nosebleed, which is the most common kind, is relatively easy to control, but a posterior nosebleed is really serious and it's going to require surgery. And you're not going to be able to get to it without surgical intervention because it's in the very, very back. All right, let's move on to another review. So this is, oops, I got to make this bigger so you can't cheat. So this is for upper respiratory. Antibiotics are used to treat bacterial infections, viral infections, are only for immunocompromised elderly patients, are effective against coryza. So coryza, what is coryza? If you don't remember what coryza is, that's a fancy name for the common cold. What is the common cold? It's a virus. So you have 2 virus options. B and D are viruses, so we're going to eliminate those. And antibiotics, think biotics, bacteria. They're not for viral infections. Are only for immunocompromised patients? Well, that's selecting a very small population. That doesn't make sense. So it's bacterial infections. Bacterial infections get antibiotics. Okay. The nurse advises the client to make sure to take the entire antibiotic prescription to avoid acquiring other conditions. What disorders may result from untreated streptococcal infections? So strep means that the bacteria are in a line. If it was staph, they would be in a cluster, like a thing of grapes. That's a staph. That's a cluster. So I think of like the little branch going through the grapes, that staph, that's a cluster. But strep is like a chain of pearls. Coccal means little ball. They're round. They're round circles. If you have bacilli, you're talking about those long rods. So you have streptococcal, which is a chain of little circles. So streptococcal look like a chain of pearls. And this is a common when people have a throat, a strep throat. When they say strep throat, this is what they're talking about. When somebody says that they have pharyngitis, it just means they have a sore throat or inflamed throat. It doesn't necessarily mean it's bacterial, and a lot of times it's not. So if you do have true bacterial strep throat and it's not treated, it can lead to several infections. So let's look at these. Select all that apply. Glomerulonephritis. This is infection of the kidneys. Otitis media. It's ear infection. Shingles. Heart valve damage or rheumatic fever. Pyelonephritis, which is an infection of the kidneys. So, can have kidney damage. Strep throat can lead to ear infection because, especially in children, because the canal is parallel with the ground. It's level in children and it's shorter. In adults, it would be an uphill climb, so we're less likely to get ear infections after a strep throat infection. Shingles is a virus, not related to bacterial infections, and untreated strep throat can lead to heart valve damage and rheumatic fever. Upper kidney infection, that's not a risk factor, but the glomerulus in the kidneys, those can be affected. But the big thing is rheumatic fever and heart valve damage. If somebody truly does have strep throat that's bacterial, they need to have those antibiotics right away. Patient education for laryngitis, which is inflammation of the larynx, includes which intervention? Sucking on ice strips, resting patient's voice, drinking hot water, or rub mentholatum, like Vicks rub, on the throat. Ooh, ow. So it's resting the patient's voice. When somebody loses their voice from yelling or whatever, that's called laryngitis. So rest your voice. The only way it's going to come back. What nursing action is essential before suctioning a patient with a tracheostomy? Pre-oxygenating, moisten the catheter, clean around the stoma, or removing the inner cannula. Which one is essential? So this is like a priority question. Which one must be done? Pre-oxygenation, you always pre-oxygenate before you do suctioning. Because of impaired speech after a tracheostomy, what nursing action facilitates optimum communication? Use lip reading, tell the client to speak slowly, listen attentively, provide the client with paper and pencil. So paper and pencil. So lip reading. Do we both know how to lip read? They just had a trach. Are they going to be speaking at all? Probably not. And you're not going to be listening attentively because they're not going to be talking. So the only option is to provide them with the paper and pencil. I need to ask the patient if they can read and write first, because they may need a picture image version. They have these charts that you can use that have common medical and like ADL activities, and you can use those pictures and they can point to them. How was laryngeal cancer diagnosed? Throat culture, biopsy, laryngostomy, CLW45 blood test. So throat culture is like when you have strep throat and they put a Q-tip in the back of your throat. It's probably That's your pharynx. That's not your larynx. A biopsy? Biopsy sounds pretty good. A laryngoscopy. That's just making an incision into ostomy. And a blood test. Nope. Biopsy. Any kind of cancer, no matter what, ultrasound, blood test, x-ray, whatever imaging you have, the definitive diagnosis is to take a piece of that tissue, put those little cells under a microscope, have a pathologist look at it and say, yep, that's cancer. That's the only 100% definitive way. Which of the following is a function of the turbinates? Turbinates are in your nose. They trap inspired particles, destroy microorganisms, warms inspired air, or detects odors. It warms the air that you inhale. Our bodies are, about 98 degrees, so we don't want room temperature air coming in. Which of the following are changes in elderly in their nose, sinuses, and throat? Select all that apply. Thinning mucous membrane, increased mucus production, nasal obstruction, more common, decreased sense of smell, less risk of epistaxis or nosebleed. So the options are they have thinning mucous membrane. We get drier and drier as we get older. So when we're born, we have a lot of water. We have a really high percentage of water in our body. And as we get older, that percentage decreases. And it decreases quite a bit by the time we're elderly. So mucous membranes are thin and they're drier. And there's not as much mucus production. Nasal obstruction is more common, and there is a decreased sense of smell. And that's it for that one. Let's do the last little review. This is kind of a case study one. So Daniel, a 71-year-old male, comes to the emergency department with a 7-day history of increased sputum production, a change in the character of sputum, increased shortness of breath, and a fever of 101 degrees. He has a smoking history, 2 packs a day for the past 40 years. He has smoked 1 pack a day prior to that, beginning at age 14. He reports that he thinks he has had asthma as a child. He has been treated with albuterol, which is a rescue inhaler, from time to time as an adult, so it wasn't really consistent with his care there. He has been hospitalized twice with pneumonia, most recently 2 years ago. What data should the nurse collect? Auscultation of breath sounds, determine pupillary response to light, observe for jugular vein distension, palpate pedal pulses. This one's pretty obvious, airway, and it's an airway issue. Pupils, not really important here. Jugular vein distension could be because of trouble breathing, but lung sounds are more important, and pulses are not as important. The nurse recognizes that which finding supports Dan's diagnosis of pneumonia? A heart rate of 115, a blood pressure of 120/80, increased anterior-posterior diameter of the chest, fingernail clubbing. That's a heart rate of 115. So he has an elevated heart rate. So he's an elevated heart rate. So he's kind of struggling to breathe, but his blood pressure is normal. So that doesn't mean anything. Increased anterior posterior diameter of the chest. That's also called barrel chest, and that's not seen in pneumonia. That's seen in emphysema. Fingernail clubbing. If you were looking for signs of a chronic, long-term respiratory disease like COPD or emphysema, then COPD and is emphysema and chronic bronchitis, then you would see the clubbed fingernails. So if you put your fingernails together with your left hand and your right hand, they should pretty much touch each other evenly. With people who have clubbed fingernails, they're really rounded and they don't touch. There's a gap. So D would be for somebody with like COPD. C would be emphysema, and the blood pressure is normal. So we're going to figure this one out. So based on these ABG, arterial blood gas results, the nurse recognized that the client is experiencing which acid-base imbalance? So we have a pH of 7.28, and that is elevated. I'm going to draw. I feel like drawing. So, oh, I'm sorry. I did that backwards. I'm going in the wrong direction here. So, a decreased pH of 7.28 is decreased. So that's low. And then a CO2 of 55 elevated, and bicarb, we're going to call that normal. Oops. Okay. Still drawing. Don't want to be drawing anymore. So acidosis is if it's less than 7.35, and we have 7.28. CO2 normal range is 35 to 55. So if it's above 45, it's acidosis. So we have a down and an up. And bicarb, we're 24, so 25, so we're normal. So if you look at Rome, we have opposite. So respiratory is opposite, but 7.28 is acidosis. So it's this one or this one. And because it's opposite, we know it's respiratory. So this is a nice little ABG interpretation. So you can pause this if you want to copy this. It's a nice little chart. And there is compensating and non-compensating, but if you just know the basics, respiratory opposite, metabolic equal, that's going to get you a long way. And if you work in a hospital or anywhere, it's really going to be the respiratory therapist that's going to draw them and interpret them and give them to the provider. So you're not going to have to use this too often for the most part. Which nursing diagnosis has the highest priority? Altered nutrition, less than body requirements, activity intolerance, anxiety related to shortness of breath, or ineffective airway clearance. Ineffective airway clearance. So somebody could have anxiety, and that's not helpful, and that's not very fun for the patient. But ineffective airway clearance is an airway issue. And then nutrition and activity intolerance are not too important. Which is the most important intervention for the nurse to implement for Dan's priority nursing diagnosis? Monitor fever every 2 hours, monitor rate and depth of respiration, provide antibiotics as scheduled, provide nutritious meals to encourage proper healing. So you're going to monitor the respiratory rate. So the priority nursing diagnosis is ineffective airway clearance. His medical or admitting diagnosis may be pneumonia, but the nursing diagnosis is ineffective airway clearance. Which outcome should the nurse expect to note in Dan's plan of care for the priority nursing diagnosis? Ambulate in the hallway for 10 minutes, 4 times a day by third hospital stay. Day, consume 100% of meals by day 2. Respiration rate will be 16 by day 4. Reduce level of anxious behavior by the time of discharge. Remember the priorities. So a normal respiratory rate by day 4. So remember, you got to wait for those antibiotics to kick in. Antibiotics should be working 48 to 72 hours after they're started for respiratory issues. So by day 4, normal respiration rate. And that is also a priority in your goal. Before administering an antibiotic, ampicillin, sulbactam, by the RN, which action should the nurse implement? Apical heart rate, O2 saturation, obtain a sputum specimen, or record a client's weight. So you're about to give an antibiotic. What do you want to know before you give the antibiotic? So you're going to give that, you have the order for the antibiotic, it's going to be given. Does it matter if you know what their O2 saturation is? Not really. Their apical heart rate, once again, not really. They're getting the antibiotic either way. Sputum sample. So a sputum sample, that is where they're looking at bacteria inside the lungs. If you give an antibiotic and then get the sputum sample, it's going to alter the microorganisms because they would have had antibiotics in there and the client's weight. Yeah, important to know, but really not going to affect the antibiotic too much unless there's a very specific weight dosage. But the sputum sample. And this is true for any type of culture. If you're collecting a culture, you want to collect it before you start the antibiotics. Otherwise, you may come back with reduced microorganisms, or you may not be able to detect that microorganisms. Then give the antibiotics. Dan has an O2 saturation of 89%. After checking the sensor site to make sure the O2 sat reading is accurate, which intervention should the nurse initiate next? Increase oxygen to 6 liters a minute per nurse nasal cannula. Elevate head of bed to high Fowler's position. Remove the pulse oximeter to reduce anxiety. Obtain and administer a prescription for pain relief. This is something that you can do right then and there. Elevate the head of bed. Even before oxygen or anything else. You can elevate the bed in a couple seconds. Which discharge instruction should the nurse reinforce for a patient being discharged with pneumonia to promote optimal health? Avoid physical exertion. Avoid crowds and people with infections. Limit oral fluids. Stay indoors except in the early morning. So you want to avoid crowds and people with infections. So avoiding physical exertion, they're not talking about to what extent. Like, are you not allowed to walk to the bathroom? Or you're not allowed to run a marathon? This isn't specific. So physical exertion, you want to exercise. You want to get healthy again. You want to be moving. Limit intake of fluids. Absolutely not any respiratory thing going on. Fluids are good unless you have fluid volume overload. Stay indoors except for the early morning. Well, are there less microorganisms in the early morning? No. So crowded people with infections, that's true for anybody that has immunocompromised. situation. So this guy's elderly. So he's 71. Anybody over 65 should be really careful in crowded places or people with infections anyway. And there are some COPD nursing care plans. I'm not going to talk about them, but if you want to stop the video and review the care plans below, you can. Thank you. Good luck with nursing school, and look for the respiratory lectures on my YouTube channel. And I hope you enjoyed this review. So here's a sample of ineffective airway clearance, impaired gas exchange, imbalanced nutrition less than body requirements, disturbed sleep pattern, risk for infection. Remember, risk for diagnoses only have two parts. They haven't happened yet, so there's nothing to evidence based. You cannot as evidence by because you haven't seen it. It's just a risk. It hasn't happened yet. So that's that presentation. I hope you enjoyed it. I'm going to sign off now.